All right, class, welcome to the thorax unit for clinical anatomy. We're going to start by going over the basics of the thoracic wall. Here are your learning objectives on which you can focus this lecture on. The first thing we'll do is take a look at the composition of the thoracic wall. So we can kind of palpate our thoracic wall pretty easily. It's a nice sternum cage that keeps our heart and lungs in check, some of our more vital organs. The basic composition as far as osteology is concerned is we have that anterior portion, which is referred to as the sternum. We have 12 thoracic ribs, and we have our 12 thoracic vertebrae that we looked at in the back unit. I won't go into too much detail as far as the thoracic vertebrae go in this region because we looked at those, but we will talk about some of the joints there. So when we're looking at the ribs, we'd like to divide those up into a true rib, a false rib, and a floating rib. So what makes a true rib is these are ribs that have a direct connection from the spine to the sternum. So we call those vertebrocostal ribs, which means you'll actually see binding all the way from the back, and I can't really move my hand behind there, but it's coming around, and then you can see some sort of joint established with the sternum. Even number 7, so our first 7 are going to be true ribs, stretches all the way up with its cartilage just to reach that peak there in the xiphoid process. After that, we have false ribs, and these are considered vertebrochondral ribs because they bind with the vertebral column. And then they don't bind with the sternum directly, they actually have to bind to the cartilage of the 7th rib here. So you can see the chondral cartilage of the 7th rib, basically receiving the false ribs from 8, 9, and 10. So no direct connection between the sternum. And then finally we have 2 floating ribs. And the floating ribs are basically just ribs that float there. It's 11 and 12, and you can kind of feel them at the bottom of what we refer to as our costal margin. They just kind of hang out there in the open. So let's go ahead and look in the composition of a basic rib. So we do want to talk about things, and anytime we're talking about structures in anatomy, we have to ask ourselves, so we're talking about a typical structure or any sort of variation, because the body likes to have variations for certain functions. So let's look at a typical rib. It's mainly divided into a head, a neck. The neck contains a tubercle, you have the shaft, and then the distal component, which is going to bind to the cartilage for attachment to either more cartilage or the sternum. So when we look at the head, it's typically going to have that wedge-shaped appearance here. So you're going to have a little articulation site, superior, inferior, make like this little wedge. So one of them is going to, each rib is going to articulate with 2 thoracic vertebrae. It's going to articulate with the one that it's associated with, as well as the vertebral body above it. And we'll take a look more at the binding when we start talking about joints. There is the neck, which is just this little portion immediately after our head. There's also going to be a tubercle, which you can usually see. This is going to be another binding site for our transverse process that we saw in our thoracic vertebrae. And then you have the shaft. And within the shaft, and you can kind of see in this image down here, we have what's known as the costal groove. And so the shaft of the rib gets really narrow and kind of pointed, and then on the inside it gets concave. And what that is going to do is allow our neurovascular bundles to just ride along the rib and be extra protected from any sort of injury. Now we can go ahead and take a look at atypical ribs. So the first 2 ribs are atypical. They don't have the same basic structure, and you can actually see the first rib here kind of really stands out in the body. It really has like a prominent, you can almost, when you're looking at the images of the cadaver, you can just see this nice flat rib for the first one. It only has 1 articulating site on the head there rather than 2. And we don't really have a real prominent neck or tubercle, but we do have a scalene tubercle, which is going to be for attachment of one of our scalene muscles that we see in the neck region. The same thing for the second rib. It also has a tuberosity, which typically the difference between a tubercle and a tuberosity is tubercles tend to be little projections. Tuberosities tend to be these long ridges on the bones for prolonged attachment. The second rib is going to have these tuberosities for scalene attachment. Well, the scalene muscles, we won't get into really heavily with the thorax. You'll see those more in the neck unit. Those play a real partial role in respiration. They kind of help elevate those first 2 ribs there, but it's not going to be a significant role. So we'll come back to those. Now the second rib does have 2 articulation sites. So where rib 1 is going to articulate with T1, vertebral body. Rib 2 is going to do T1 and 2, and this is going to start a trend that we see where a rib is going to bind with the rib of the same number, or the vertebrae of the same number, as well as the one above it. So keep that in mind. A couple other things to note is ribs 11 and 12, those floating ribs don't have any necks or tubercles. They're just kind of like hanging out there, and they only have 1 faucet for articulation. That doesn't mean they only articulate with 1 vertebral body. But it's just a single articulation site, so it's what we'll see with the point of having that wedge shape is it really helps kind of add some motion and allows our ribs to do this sort of rocking body, what we actually call a bucket handle motion when we talk about breathing and inspiration. So we'll see that soon. But the bottom ribs 10 through 12, don't really have a significant need for that. Most of that uplifting comes from our upper top ribs. Basically, our true ribs primarily do a lot of that lifting because they're holding onto the sternum and helping to create this increased volume inside. We don't really need that for some of our lower numbered ribs. All right, and then the sternum, so that main kind of plate in the body, is divided up into 3 parts. So you have your manubrium here, which we can all palpate. And that's going to be a key anatomical feature up here you can feel is called the jugular notch. It's just sort of the top part of the manubrium. We have the manubrial sternal joint, and this is another palpable structure that we'll talk about. It creates this angle of Louis or sternal angle. So you can actually see that the manubrium kind of pops out and then the sternal body kind of pops in, so it creates this sort of jointed angle. And then finally you have the xiphoid process. The xiphoid process kind of marks the inferior boundary of the costal margin. It also marks kind of the most superior aspect of the liver, so it's kind of important for a lot of palpation and landmark imagery for our body. You'll see a lot of times when you're doing things like CPR, you want to identify where that xiphoid process is and kind of go above it. It'll help give you kind of an idea of where your chest compressions need to be held. It is a small little predominantly cartilaginous structure, so it's easy to break. That could cause other issues if it does break off. So it's definitely a concern if you're doing things like CPR. Like I said, thoracic vertebrae, we're not going to get into too many details. I won't test you guys on the specifics of the vertebrae. The things I want you to notice here, you can't really see in the image. My image isn't that great, but we have these articulating faucets for the ribs. And so we do have a transverse faucet, which you can kind of see on the transverse side. And then we have our demifaucets on the body, which is where the head is going to articulate. So we have the tubercles on our ribs that are going to articulate on the transverse process here. And then the heads with those wedge-shaped faucets are going to articulate on our intercostal faucets here. I should just say costal faucets, sorry. So let's take a look at how that plays out. So if we look at our thoracic rib cage, so hopefully you can now see we've got superior and inferior costal faucet, or they're also called demifaucets, on our ribs or on our thoracic spine. So when we see the join up right here, so you can see where the arrows are kind of coming together, that's where one rib is going to insert. So a rib is going to insert into an inferior costal faucet and a superior costal faucet from 2 vertebral bodies. And then it's also going to articulate with the transverse process of the same numbered rib there, or the same numbered spinal column. All right, so I mentioned reference lines. Let's take a look at what those look like. So some of the ones that you really should be mindful of are that jugular notch. So that is a reference point for identifying where your T2 vertebral body is. So if you can find where your jugular notch is, should be pretty similar. Easy to do. You can see where your clavicles come together and just that midpoint there. That's going to be your jugular notch. That sternal angle is a key point, and we'll see this as useful for a lot of structures. T4 tends to be a designating spot for where our aortic arch is. So you can kind of use that to get an idea of where that aortic arch is, and we'll take a look at that when we get into the mediastinum. But that is a location for your T4 vertebral body. And then finally we have the xiphoid process at the end, and I'll step out of the way here. But the start of the xiphoid process, the xiphoid sternal angle or joint, is at T9, and the bottom of the xiphoid process tends to be about T10. So you can kind of see where that costal margin will sort of end there. And when we do say costal margin, what I'm referring to is basically if you were to palpate your rib cage, you can kind of feel where it makes this sort of like upside down U shape, so this like teepee shape, I guess triangular shape. And it's what we refer to as a costal margin. And that basically is everything above that is going to be within the thoracic cage, and everything below that is predominantly our abdominal cavity. But our diaphragm, when we look at that, actually kind of peeks up into our thoracic cavity. And so what happens is you'll actually see structures like the liver and spleen are protected by that rib cage. So you can see ideally under normal palpitation, we shouldn't feel things like our spleen and we shouldn't feel our liver. So when we're going in for an examination, you can determine things like Maybe there's a hepatomegaly or splenomegaly, because you can actually start feeling these structures kind of dipping underneath the costal margin there. And you shouldn't normally feel them. So if someone has something like a liver cancer, hepatocellular carcinoma, then what they're going to ultimately feel is like, oh, I can feel some nodularity kind of protruding out from underneath your costal margin. Leukemia patients tend to, or anyone suffering from sort of any lymphoid disorder might see splenomegaly. So their spleen might get really large and you can start palpating that. So normally the rib cage is actually protecting our vital organs, but sometimes when those things get a little bit larger, they start to become a little more exposed, and the image kind of demonstrates that, especially down here below with our liver. All right, so now let's start getting into more detail about those joints I kind of mentioned. So the first joint I want to talk about is the costal vertebral joint. So we looked at the costal facets on the vertebral bodies, and we also looked at the facets on the head of the ribs. And those are the main factors for these costal vertebral joints. And so what we see here is we have the inferior facet for the ribbed or the thoracic body superior, and then the superior facet, superior costal facet for the vertebral body inferior. Now, I think I mentioned already that if you have a rib, it's going to articulate with the same numbered vertebral body plus the one above it. So if we'll use rib 6 for our example here. So let's say this is rib number 6. That would mean that it's articulating with the superior costal facet on vertebral body T6, as well as the inferior costal facet on vertebral body T5. Okay? So keep that in mind. And then there's also that articulation. We'll see the costal transverse joint here. That happens on the same numbered rib. So we'll take a look at that momentarily. So once we have our ribs kind of locked into place on our spine, now we have to articulate with that transverse process. So we have the tubercle that exists on the start of the neck for the rib, and we have that facet on the transverse process there, and that's going to be on the same numbered rib. So a rib same numbered thoracic body. So a rib should articulate 2 sites on the vertebral body with the same number. So again, we'll go back to 6. We know that it's going to articulate on the superior costal facet on T6, as well as the transverse costal facet on T6. It's also going to articulate with 1 site on the rib above it, or the, sorry, I keep using ribs in terms of thoracic body, but the thoracic body above it. So the inferior costal facet of T5 is also going to bond with rib 6. So hopefully that makes sense. So do a little practice exercise, and that's predominantly for when we talk about this, unless I specify, it's going to be typical ribs. So those are the ones where these dual joints become more key, because we'll look into the ways they help with not restoration, but respiration. So we'll look at the ways those help with respiration. Okay, now let's take a look at the joints of the now let's take a look at the ligaments that secure the costal transverse and the costal vertebral joints. So when we're looking at the head of the rib, we have a what's known as a radiate ligament, and what that's going to do is kind of create this little like web capsule that secures the head of the rib to the thoracic bodies. And so it's got to actually bind to the rib head, as well as the thoracic bodies of the same numbered rib, as well as the rib or the thoracic body of the one before that. Additionally, if we're looking at a wedge-shaped head with 2 facets, got that superior facet on the rib and the inferior facet, we've got that little wedge shape. You'll also get an intra-articular ligament that's going to bind that sort of point to the intervertebral disc. Okay, and that gives it a little bit added security. The costal transverse joint has a couple ligaments to be mindful of too. So you're going to have a costal transverse ligament, which is going to basically bind, you can kind of see it here. Let's see, I don't know if my binding. So basically we get the neck of the rib is going to bind and tame. Okay, so let's take a look at the joints of our heads and transverse processes. So they have a couple of ligaments that are going to help secure them in place. If we're looking at the actual head of the rib, we have what's known as a radiate ligament, and that creates sort of a webbing around the head of the rib, attaching it to both the thoracic body from the same numbered thoracic body as well as the thoracic body above it. And that'll help secure it. We want these joints to be a little more mobile. We'll see shortly. We'll also, if we take a look at the structure of a typical rib, right, so it's going to have that wedge shaped on the head. You got a superior facet and an inferior facet. So we need some binding to kind of help secure that in place. And that's what the intra-articular ligament, which is labeled there, does. It basically takes that point at the tip of the wedge and helps secure that to the intervertebral disc. And that kind of gives it a little more added security. Now, for the costal transverse joint, we have a couple of things to worry about. So the first I'm actually going to point out, because it's the easiest to identify, is if we imagine our ribs kind of wrapping around. So I'm going to use my hands often as like ribs, right? And I'll use my body as a spine. So if these are wrapping out, we have lateral costal transverse ligaments, which are basically going to take the from the tubercle, the binding site on the rib, and attach laterally. So they're going to actually come out where my arms would be, so heading towards my elbows. So those help kind of secure those joints in place in a lateral direction. We also have direct attachment just within the joint. So you have the neck of the rib attaching directly to the transverse process through the costal transverse ligament. So basically it's just a straight shot. It's if you have your joint, your joint lined up here, you can see the costal transverse ligament basically attaches to the transverse process moving anteriorly. So here's our lateral transverse, and then there's our costal transverse ligaments. So it kind of secures it. Additionally, there's the superior costal transverse, which we don't really see in this cross section here, but that basically goes from that tubercle in the neck of the rib and attaches to the transverse process superiorly. So we're still involving that superior thoracic body. The other thing is now we have costochondral joints. So there isn't a direct connection of the rib to the sternum. First, we have to actually get cartilage involved. So what you'll see here is every rib, except for the floating ribs, is going to have a costochondral joint. And these are nice and secure joints and basically extend the length of the rib so that it'll reach that sternum. So these are non-moving joints, and these are going to just create this hyaline cartilage joint, or the costal cartilage is hyaline cartilage, which is a little more firm cartilage. We want it to kind of have a little more rigidity to it. But what we'll see there is all those ribs have this costochondral non-moving joint forming here. And then they have our hyaline costal cartilage, and then what we'll get is our sternocostal joints. So the thing that's technically binding with the sternum is our hyaline cartilage of our costal cartilage. Okay, so the first one only articulates with the manubrium. So you can kind of see up here we have our jugular notch, we have our first rib binding with our manubrium. This is a sternocostal joint. We want these to be very similar to the joints that we saw with the vertebral bodies and the rib heads, because we're going to need some motion and movement to help kind of keep those ribs as flexible as possible. So we'll see they have very similar structures, namely they have that radiant ligament that's going to be like that webbing that wraps around the joint, or this isn't the joint head, but basically that attaches the hyaline cartilage to the sternum. And this is going to allow for some movement, and we'll see how this plays a role. I got a little bit of an example coming up. Additionally, so that's going to be for all our primary true ribs. Additionally, we want to see interchondral joints, and that's just a joint between two sections of cartilage. So we can see that because you actually, even though 6 and 7 are true ribs, there is an intracondyle joint that secures them. So you actually see that, and so all these other joints all the way up to rib 10 still binds to cartilage. So it's cartilage to cartilage joints. We just refer to this as intracartilage. A couple other things to worry about. I'm not too picky with the clavicular stuff. That's mostly associated with neck, but just be mindful because it does kind of create our thoracic aperture up here, but we do have a sternoclavicular joint, which is going to be, so you can see our rib 1 down here, clavicle is going to bind right superiorly to that. So a couple of ligaments to be mindful of is our anterior and posterior sternoclavicular ligaments and our costoclavicular ligaments. And the nice thing to know with these, the way you name these, is just take the directions and the terms in there. So if we know that costal is being included, we know that that binds to the ribs. So let's say our costoclavicular ligament, for example. Costoclavicular means rib clavicle. So those ligaments should be binding, which you can kind of see here, the clavicle to the first rib. We have anterior and posterior sternoclavicular ligaments. So you'll actually see on the anterior side of the clavicle binding to the sternum and the posterior side as well. And then the intraclavicular are basically going to do the same thing that we saw with kind of with that intra-articular one on the sternal-vertebral. No, not sternal, the vertebral costal joints. But that one's going to actually be kind of inside and just sort of binds both sternums together. Like I said, I'm not too picky on these structures as these ligaments go, mostly concerned with the ones that are primarily for respiration. So let's take a look at how respiration works then. So we need both our costal transverse, our costal vertebral, and our sternal costal joints to play a role. Okay, so the first thing we'll look at is our costal transverse joints. So that's going to be that one that's going to be on the neck of the rib with our transverse process. And the way this works is we want there to be some sort of rotation. So the goal with this joint is to increase anterior and posterior diameter. So what does that mean? All right, let's see if I can do this with my hand examples. So normally our ribs are kind of dripping down a little bit, right? So if we're paying attention, you notice, hey, on our jugular on our jugular notch, you said it was an indication for T2, but T1 or rib 1 binds there. That's because if we have T2 back here, the rib from T1, and my anatomic orientation is not specific, but I'm trying to do this for identification purposes. T1 is going to be a little bit higher, but the rib actually dips down, right? And so the first rib is actually going to be kind of in front of our second thoracic vertebrae. And it kind of gets more pronounced as we go down. So just be mindful of that. So our sternum kind of hangs down a little bit. So when we are inhaling, we want to increase the diameter. So what we're going to do is we're going to lift our sternum up and kind of make it more in line to basically what it should be if you were thinking about just the ribs basically wrapping around instead of going down like this. So we basically want our ribs to kind of lift up. And that's where the costal transverse joint comes into play. Okay, and the way it does that is we want it to help rotate, and we also, for some of the lower ones, so you notice it says, so we want rotation on those true ribs, and those false ribs, we need it to glide. And what that means is, because if you think about it, the false ribs in this diagram here, they have to go a little bit farther, right? So if you're thinking about, let's say, we might have all done this in grade school, when you're like running around holding hands, and the person that's out at the farthest end has to run the fastest because they're kind of like covering more distance. It's the same for our false ribs. So they actually not only have to rotate up, they have to glide forward to help increase the anterior posterior diameter. I'll try to include some videos of this to make it a little more sense, but basically think of that for our costal transverse, we're increasing our anterior posterior diameter. And when we talk about the gliding versus rotation, we only need the higher ones up to just kind of like rotate. That's all they have to do. Where those 8, 9, and 10 have to like rotate and push up to make sure that sternum's really getting up there. So we really increase our diameter. Now, let's look at the joints of the head as well as the sternocostal joints. So these ones we saw that those have radiate ligaments because we want motion there. And this creates what's known as a bucket handle movement for the rib. And the goal here is we want to increase our transverse diameter. So not only are we increasing anterior to posterior, so like let's say here, let's see if I can get more into camera. Here's my anterior posterior, right? This is under normal resting conditions. Now I'm going to inhale, I breathe, and just that lifting process increases my anterior posterior. That's a costal transverse joint. And now I want to increase my transverse using my the heads of the ribs as well as the sternocostal joints. And what that is going to do is kind of do like a chicken wing sort of lift on the lateral aspect. So what's happening is lift, expand. Right? Now, I do happen to have a bucket, and hopefully this will help with demonstration purposes, but let's say this is our sternocostal joint, and this is our costal vertebral joint. So those need to basically just be able to hinge on lateral sides. So if this is under normal conditions, I breathe in, breathe out. And what you'll notice, and this isn't really the best example because what's happening is typically you have to go from underneath to up to increase the diameter, because right now it's increasing when I go laterally. If that makes sense, I'm trying not to hopefully confuse anyone. But it's just kind of showing you the fact that, let's say, and I don't want to tip this because it does have sand in it, but let's say this is our joint, right? So we just want it to, let's start down here. We want it to lift, and we actually increase the diameter this way, which is our transverse diameter. So why do we want to do that? Well, when we think about going back to our basic physics, right? Anytime we increase our volume, we decrease our pressure. And that's going to create a nice little pressure gradient for air to go into our lungs. So by breathing, we do our costal transverse joint up, our sternocostal and costal vertebral joints out. I've just basically greatly expanded the volume of my lungs in my thoracic cavity. And we'll see how that works when we get into the lungs. But now I've decreased the pressure, so it's not that hard for air to just want to go into my lungs. And that's the basics of respiration. So again, I'll try to post some videos to hopefully make that makes sense. Don't focus too much on like the bucket handle versus the pump handle thing. Those are just terms that are commonly used. Just think about how that would work, right? So if my transverse joint's going up, and then that kind of like lateral radiant ligaments are letting my heads and distal components go out, it's just going to create a better environment for breathing. Okay, so speaking of breathing, let's take a look at some of the musculature that's predominantly helpful for keeping us alive. The most prominent of such, and the main muscle for respiration, is our diaphragm. So our diaphragm is a big chunky muscle, and you can see that it basically creates the floor of our thoracic cavity, the ceiling of our abdominal cavity. It's got this nice big tendon that's musculotendinous center, where everything can kind of attach. If we were to look in the abdominal cavity, we can see 3 points. So basically you'll see it attached to the costal margin along the edge. So you'll see that costal part. You'll also see it attached to the vertebral body, so the lumbar spine there. And we also have a little bit of attachment to, right there, our xiphoid process sternum region. So it just creates this nice little floor, and you can notice that it's domed into thoracic cavity, okay? So what's gonna happen is during inspiration, which is when we breathe in, the diaphragm is gonna drop down. So now, what does that also do? You took something that was kind of expanding up and you dropped it down, we've increased our volume some more. So that's the third potential way for us to increase our volume. So combine that with the way our rib joints are gonna move, we've just really assisted our body in helping make air come into our lungs. And then when we do the opposite, and we just kind of relax and let our rib cage kind of shrink, our diaphragm go back up, everything just kind of naturally exhales. So as long as you're just normally breathing, cavity expands, everything shrinks and just pushes that air out. We've increased our pressure, air wants to leave our body now. Okay, so the diaphragm is our main number one inspiration muscle. Now, as far as other muscles, so we have our intercostal muscles. So if you look at the rib, it's just covered with these muscles. And again, when we're saying costal, costal means rib. So intercostal means between ribs. So we have 3 layers of intercostal muscles. Now, the way to remember these, so we have an external intercostal muscle, then we're gonna have an internal intercostal muscle, and then we're gonna have an innermost internal intercostal. So it can get a little tricky. Now, when we're looking at our external intercostal, so when we say this, the fibers are going to run anterior to caudally. What does that mean? So it's going to start at the back of my spine here, and the fibers are going to move up. Now, what I like to use as a demonstration is kind of a hands in pockets. Let's say you're going to put your hands in your pocket. the way your fingers are going is the way that these fibers are going to run. So when basically they're attaching back here, they're going to move anteriorly and then caudally towards our feet, right? So hands in pocket, external intercostals. And you can apply this same practice for when you get to the abdominal muscles as well. So then, once we get past that, the one thing to note about our external intercostals is right about when we get to the cartilage region, so our costal cartilage, they become membranes. So they're muscles right about to here, and as we get more anteriorly, they start becoming membranes. So technically, if we were to tag a structure, and you could see that the fibers are still going the same way, because you can actually see the fibers running in the membrane, and it's a superficial component, it is an external intercostal membrane. And I don't think it'll be that tricky for you guys, but it's just something to be mindful of. Now, the other thing is right under that, you're going to have your internal intercostals. And so if we're keeping our hands in pockets analogies, so we put the hands in pockets just like that, external intercostals. And then you can do a little hip hop, and that's your internal intercostals. Fibers are basically going to run in the direct opposite. So now if I'm kind of wrapping myself around like this, giving myself a hug, I can see that the fibers are going to move towards the posterior aspect. So they do a 90-degree split on the external intercostals versus internal intercostals. It gets tricky because when we look at the innermost internal intercostals, they run the exact same way as the internal intercostals. But I'll show you how you can separate those. Now, just like we saw with the external intercostals, the internal intercostals also have membranes, but that's going to be located more posteriorly. So if you are looking at a structure, let's say you're looking at musculature on the thoracic wall here anteriorly, and right around here you actually see, and you're like trying to figure out, is it an internal intercostal or external intercostal? I can't really tell, the fibers are moving. If you see musculature right around here, chances are it's not an external intercostal muscle. Okay, it's just going to be an internal intercostal, and you have to decide if it's innermost versus internal. So the other thing to keep in mind now is, like I said, the fibers of the innermost intercostals are going to run the same way, but the thing that's helpful is there should be a neurovascular bundle separating your internal intercostals from your innermost intercostals. So you can actually see our intercostal vein, artery, and nerve bundle here. And what that's going to do is, if we were to look on the opposite side or toward the inside, you would have your innermost. So it should go external, and there's a cross section we'll see in the next slide that'll do that. External, internal, neurovascular bundle, innermost internal. Okay, so if that's kind of like, oh, mind blown, wait till we look at a cross section, because then after that we have the deepest muscular layer is referred to as a subcostalis muscle. Now, these are often hard to see, but the fibers run very similarly to an internal intercostal, except they have to cross a rib for a subcostalis. So if you were to look at the inside of the thoracic wall and you see a muscle like you see here kind of crossing a rib, it's no longer an intercostal, it's a subcostalis muscle. Okay, so this is kind of like what I was saying before. So nice cross section. This is how you can remember those internal versus external versus innermost internal. It's a lot of naming conventions here. But our external is going to be our most external structure here, right? And so remember, our fibers go anterior to caudally. Then behind that is our internal intercostals, and those fibers go posterior caudally, so we crisscross. Then you get your neurovascular bundle, and then you get your innermost internal intercostal. And if we were to see ones that cross the rib, those are subcostalis. And then you also have endothoracic fascia. So we talked about fascia before, and it's basically going to be this like connective tissue component that sort of houses all that. And then just deep to the endothoracic fascia is what's referred to as a parietal pleura. And this helps create sort of a slick space for our lungs to kind of expand and contract. And when we look at the lungs in a little more detail, we'll see how that works. So hopefully this diagram helps you a lot as far as keeping those in track. So again, when you're trying to remember them, think about if you were to ever see these, you usually need to see a neurovascular bundle to make sure you know which one you're looking at as far as internal and innermost internal. But otherwise, you can look at the fibers. Another one that we use for respiration is an internal muscle. This is going to be within, so kind of like our subcostalis. All these have to be on the outside. We don't want these in our lung cavities at all. So This is all before we get to that endothoracic fascia. So you will see coming from our sternum, transverse thoracic muscles. And so what they're going to do is they're going to insert on the ribs. They're going to start at the sternum and kind of insert. And what they're going to help is, again, kind of contract the lungs or contract your costal ribs for respiration. So this is another one. They're not as prominent as diaphragm and then intercostals. And then one that helps with inspiration, we looked at in the back, is our levator crustarium. So these are, again, not anything I'm going to really test, just might be mindful that you saw them in the back, and these are going to be another key muscle for inspiration, keeping ourselves alive. So they help elevate those ribs, and when we elevate the ribs, increases diameter, increases inspiration. All right, so let's take a look at the arterial supply. So the posterior aspect is pretty straightforward. That's all going to come from the the thoracic aorta, creates these posterior intercostals. Now we do have to be mindful because the intercostal arteries and veins have a posterior and an anterior division. We won't see that in the nerves. But as we continue down on our thoracic aorta, basically gives off these small little vessels, and those are our posterior intercostals. And those are predominantly going to be for ribs 3 through 11. Ribs 1 and 2 have something a little bit different. So when we look at the subclavian in a little more detail, you'll see some of these main branches. But first, the subclavian is going to give off a costal cervical trunk, which is going to give us a supreme or superior intercostal. And additionally, and that'll kind of provide some backup for like a mock posterior intercostal. In our internal thoracic, which is an anterior structure coming off of the subclavian, is going to give us an anterior intercostal, which will help supply the anterior components for 1 and 2 as well. So these are a little bit different, so be mindful of their uniqueness. So we're going to get our superior intercostal thoracic basically giving us a couple branches for our first 2 ribs posteriorly, and then our internal thoracic is going to provide additional structures for our anterior intercostals. So that's going to be the rest of our supply. So quick review, we have posterior intercostals for ribs 3 through 11 coming from our thoracic aorta. We have the posterior intercostals for ribs 1 and 2 coming from our costal cervical trunk. And then we have also coming off the subclavian is our internal thoracic, which is going to start our anterior intercostal process. So we can see that coming down here. It's just going to be the internal intercostal, sometimes referred to as the mammillary artery. And that's going to give off anterior intercostals for the first 6 intercostal spaces. Then after that, our internal thoracic is going to split into a musculophrenic, which kind of rides the costal angle, and an superior epigastric, which we will look at more when we get to the abdominal structures. So those are going to help to provide some collateral flow. So we talked about that when we're looking at vessels. And so 1 through 6 is all internal thoracic, and then after that, right about rib 6, when we start seeing the costal margin kind of separate out, and we have the musculophrenic, that's when we have the remaining anterior intercostals being supplied by that musculophrenic artery. We also see so we looked at the axillary artery in our upper extremity unit, and so some of those vessels are actually going to supply some collateral blood flow to the intercostal spaces as well. So namely the lateral thoracic and the superior thoracic, which you looked off. So those they're not main, so those 2 vessels, lateral thoracic and superior thoracic, supply blood to a lot of other areas, but they're also going to give blood to some of the anterior intercostals in this region. Okay, now we want to look at the diaphragm. So the diaphragm is going to mainly receive blood supply with branches from the pericardiophrenic, which is a branch of the internal thoracic. The musculophrenic, so we looked at that. It's going to come, well, we don't have our costal margin here, but that musculophrenic is going to be a deviation of our internal thoracic. That's going to supply blood to the diaphragm here. And then when we get down into the abdominal cavity, the aorta is going to give off these inferior phrenic arteries. One thing to be mindful of, again, terminology is important. When you hear the word phrenic, you should automatically be thinking diaphragm, okay? Now, that's it for arteries. I find the vein supply is actually kind of interesting in the thoracic cavity. It uses what's referred to as an azygous system. So we still have our paired in anterior and posterior intercostal veins. But when we look at the posterior, it's actually going to drain into a system called the azygous system, which you can kind of see mapped out here. So we'll focus mostly on that because the anterior is pretty straightforward. We have an anterior intercostal draining into the internal thoracic vein, which is then going to get into the vena cavas that way. So that's pretty straightforward. It basically just mirrors the anterior structure that we saw with the arterial supply. But you should be mindful of our azygous system for the posterior aspect. So namely on the right side, we have the azygous vein, and that's going to receive your posterior intercostal veins from the right side. The left side, now if we were to identify this, there's a lot of variation. You're going to have a hemiazygous vein, an accessory azygous vein, and they don't often meet. Let me move over here. So usually your accessory, A, is above. So anything on the left side is going to be a hemiazygous vein. And if it's above or top or superior, think accessory, and if it's below, it's hemi. And those are eventually going to kind of drain into the azygous system, which is going to eventually drain into our vena cava system. But those are going to receive posterior intercostal veins from the left side of the body. So you can kind of see how the blood's going to come around on the right side, on the left side, eventually kind of merge into this azygous vein, and then just dumps into our vena cava system. So it's kind of a neat system. And actually, because there's some collateral between the inferior and superior vena cava, we can see this tends to be an area where a lot of blood can kind of return in multiple directions. So we'll learn about collateral blood flow for some of these organs, especially when we start getting into things like esophageal varices and the abdominal tract. A lot of that can be a result of something like this. If you have communication between your superior blood supply versus inferior, it makes it easier for blood to bypass your portal system. But I'll save that for Dr. Sklazian. So here's another look again. You can kind of see a lot of things, a lot of the azygous system is kind of variable, so just be mindful of that, especially on the left side here. Like I said, sometimes our hemi and accessory will actually merge first and then merge into the azygous. Sometimes it'll just be one whole vessel. So just be more familiar with, well, we always tell you guys that anatomy is about relationships, so try to find as many vessels as you can, try to see where that split is. And if it's going to be tagged, usually think, okay, if it's tagged on the right side superiorly, I should be accessory hemiazygous. If it's inferiorly, hemiazygous. And if it's on the right side, azygous vein. All right, nerves are a little different. So we only have one intercostal nerve, basically supplying that entire neurovascular bundle there. So we looked at the posterior rami that are going to do a lot of the back muscles. All our ribs are going to be supplied by anterior, the intercostal nerves are going to be supplied by the anterior rami, and those are just going to radiate out and go the entire route of our body there, or our ribs. Now the thing to keep in mind, so we see that T12 is a subcostal nerve. We'll see that when we get to our lumbar plexus. Anything that's basically, all this stuff applies to T1 through T11. When we get to T12, it's not an anterior versus posterior intercostal artery or vein, it's just a subcostal artery, subcostal vein, and subcostal nerve. So it's a little bit separate. We'll see it more because all those structures are going to be more identifiable in the abdominal section. But that's why there's a separate name for them. So anything that you hear is subcostal, which is not to be concerned with or confused with the subcostal muscle, is actually going to be a T12 association there. And then the diaphragm, so what is making that big guy move? You may have heard the mnemonic, and if not, I'll introduce you to it. So C3, 4, and 5 keep you alive. So that is the root of our phrenic nerve. And so the phrenic nerve is going to come down, and it supplies motor innervation to our diaphragm. And that's the primary our primary muscle for respiration, and that's where it receives pretty much all its motor supply. So it's just the phrenic nerve. The phrenic nerve is also going to do sensory, so you can see these sensory fibers. It's going to supply sensory for the pericardium that we'll look at when we get to the mediastinum, as well as sensory for a lot of our diaphragm and some of our parietal pleura that we'll also look at when we look at the lungs. But that's kind of the gist of it. So that's the intro to the thoracic wall and basic inspiration, expiration stuff. And then we'll continue this by looking at some of the organs on the inside. Thank you for joining.